5, 4.
3, 2, 1. Welcome, everybody, to County Durham CCG Primary Care Commissioning Committee. Just to let you know that this is being live streamed, so important that you are in focus, and you should have received the etiquette and protocol instructions to assist us go through the live streaming process. Live streamed on Twitter and Facebook. Interested to see how many hits we get, but always useful to trial out new things in unprecedented circumstances. We are quorate. This meeting is being held in public, but because of the virtual approach that we're taking, we're not expecting anybody to participate, and hopefully they'll look at the live streaming. We have had no questions from the public, which is the standard requirement for this committee or any of our public meetings. If you could mute your telephones for the duration of the meeting, that would be much appreciated. We've got people in the background like Amanda, who's coordinating the live streaming dimension, and Lee, who is supporting and assisting in that process. So let's go straight to the agenda. We're hoping to be done by 2:15. Ian Davidson will be joining us around 2 o'clock to talk to us about the flu campaign. I have not received any apologies for absence, so we have a tentative Health Watch attendance, but David Logan, I don't think has signed in yet. And of course, as I say, Ian Davidson will be joining us at 2 o'clock. Welcome also to Anne Greenlee, and welcome. And I think as this is a live stream, it's important that we all go around very quickly to say who we are and our designation, please, so that members of the public, when they do watch this, will know exactly who we are. So, Faisal Jasset, I'm a lay member for County Durham CCG, and I chair this committee. My responsibilities fall within public patient care or engagement. Nicola.
Yes, Nicola Bailey, Chief Officer for the CCG.
Jonathan.
Jonathan Smith, I'm a GP and Chairman of the CCG.
Stuart.
Stuart Finley, Chief Officer for the CCG.
Andrew.
Andrew Atkin, I'm lay member and Vice Chair for this committee.
Anne.
Anne Greenlee, I'm on assignment to the CCG as Director of Quality Improvement in an interim role.
Jason. You're on mute, Jason.
I'm on mute. Hello, Jason Kramis, Interim Director of Nursing.
And welcome to Jason, and welcome to Anne. Joseph.
Thank you.
Joseph Chandy, Director of Primary Care, and I'm a non-voting member of this committee, purely in attendance.
David.
Dave Steele, Primary Care Manager, NHS England.
Richard.
Richard Henderson, Chief Finance Officer.
Dilys.
Dilys Swallow, GP, one of the Executive GPs for the CCG and a PCN Director.
Mike.
Mike Briley, Director Lead for Mental Health and Learning Disability.
And finally, Sarah.
Sarah Burns, Joint Head of Integrated Commissioning for the CCG and Durham County Council.
Welcome one and all. We'll move straight to the agenda. Thank you for that. We're not expecting anybody else. We are quorate. We've dealt with apologies. We've dealt with introductions. Declaration of conflicts of interest. The nature of this committee means that our clinicians and one other, non-voting, are conflicted, and each item we have captured direct, indirect, financial, etc., so that we have a record. So our clinicians will always declare, and we have a list that's managed by our administrator, Susan Parr. So we will capture those accordingly. Identification of any other business. Oh, I should say, actually, if anybody wants to ask a question, please do, because as your chair, I'm multitasking. I can't see you. I'm looking at the agenda at the moment. But if you do have a question, please feel free to say, can I ask a question? Identification of any other business. I'd like to add 2, if I may, please. Came on very late. One is an update on our local implementation scheme. Stuart, will you take that under AOB? Thank you.
Happy to, Faisal.
Thank you very much. And the other that I've just thought of, actually, if it doesn't come up under the primary care update, Joseph, is our role as primary care providers in support of the Stanley Empire COVID outbreak. So just to get a position in terms of how we're supporting Director of Public Health and Public Health colleagues and what we're doing to give us an idea of our support and response in terms of the North Durham COVID outbreak. If it doesn't come up under primary care, Joseph, we'll pick it up under any AOB. But I think primary care should do it.
Yeah, we'll do it under AOB. I'll probably ask Stuart and Sarah to pick that up because it happened while I was on holiday last week.
Okay, at least we have it covered. It's important we do.
Yeah.
Can we accept the minutes of the meeting on the 16th of June as a correct record? Yeah, we won't let Charles to look at that, so we accept those as a correct record. And before we take matters arising, I'm just going to go to the action log. Bear with me. And the action log, I know that there are a couple of items on the action log. One that had Joel Findley's name against it, I would suggest is closed, because there was a question in relation to why CCGs were not anonymized on CERM's reporting, and our response is as noted. So unless there's anything else to add on that, can we accept it as actioned? Agreed? Yep, thank you. And the second one, Nicola, we've got your name against this, and it's about future meetings as we move to the new normal. So over to you, Nicola, please. Nicola? I think Nicola may be muted.
I am, sorry, Faisal, I was muted. I was just trying to pick it up. I think what we decided to do in relation to future meetings, in the past, obviously, we've had meetings in public, and it's not appropriate at this point to have physical meetings again because of the COVID issues. But what we have decided to do is to continue with the meetings on Teams as we have now, but to actually ensure that we are able to live stream those meetings. If members of we will advertise the meetings. If people have questions, they can submit them to the CCG and we will address them as part of the live meeting.
Thank you, Nicola. That's a very straightforward position. Any comments, observations for Nicola? I think that makes a great deal of sense. Thank you for that, Nicola. So that's the action log, colleagues. Are there any other matters arising that are not reflected in the action log, please? Does anybody have? I must just say that I can always see 9 people on Microsoft Teams, but there's a whole range of people who are listed at the bottom, so I can't see you, and I'm not looking at my chat function just yet. So please, if you have an issue, please say. Thank you so much. Okay, moving swiftly on to items for decision. Our first item for decision, we've got David Steele, NHS England and Improvements, one of the primary care managers, to lead this item with our Director of Primary Care, Joseph Chandy. This is application for merger of Gardiner Crescent Surgery and Craghead Medical Centre. Colleagues will recall that we did receive information on this at our last committee, so a fairly straightforward item, I would have thought. But David, please take us through this, and Joseph, come in after, if that's all right.
Thank you. Application has been received from Gardiner Crescent Surgery and Craghead Medical Centre to merge the 2 practices as at the 1st of September. If approved, it is intended that the PMS agreement for Craghead Medical Centre will terminate and the PMS agreement for Gardiner Crescent Surgery will remain in situ. The practices have identified the following rationale for the merger. Patients can access services from both sites with access to a wider range of clinicians. Dr. Dunny intends to retire, and this proposal secures continuity of services, economies of scale in merging back office functions with the potential for additional clinical roles. From a premises perspective, this proposal does not identify premise change. The lease on Gardner Crescent Surgery will end October 2020. There is no signed lease on the branch site at the Lavender Centre, and the CCG have been facilitating discussions regarding the assigning of a new lease for Crackhead. Patient and stakeholder engagement took place from the 5th of June to the 30th of July, with letters issued to all patients, information made available on practice websites and social media. An online patient survey was also made available, with a total of 339 responses received. Concerns raised including the future of the branch site and the potential for further travel for patients. Full stakeholder engagement was undertaken with 3 responses from OSC, local MP and the Parish Council. Both responses raised concerns regarding the timing of the merger during a pandemic. Sorry, I've jumped a bit. The OSC and local MP were fully supportive. However, the local parish council raised concerns regarding the future of the branch site at the Lavender Centre. NHS England also contacted local practices with 2 responses received prior to the completion of the report. Both responses raised concerns regarding the timing of the merger during a pandemic, workforce pressures and the impact on the PCNs due to the large geographical boundaries, also impact on community services and diluting of patient services. It is understood that subject to approval is intended that Gardner Crescent will remain in Chelsea Street PCN, with Craghead becoming a branch site and will be a non-core member of Durham site PCN. There are 2 options available. Option 1 to approve the full merger of Gardner Crescent and Craghead, or option 2 to reject the full merger. The committee is asked to consider the content of the report and decide whether the application is approved or rejected. Should option 1 be approved, this is subject to the actions included at 5.2 of the report.
Thank you, David. I have a question, but I'll ask Joseph to supplement any other information before we take questions. Joseph. You're on mute, Joseph.
Sorry, Chair. Thank you, Chair. So I'm speaking in support of the proposal for the merger of Crackhead and Gardner Crescent. Gardner Crescent in this proposal remain the dominant code, and the Crackhead code will fall away. Dr. Dunny proposes to stay on to support the practice on 2.5 sessions for a period of time until retirement. Already the practice has had expression of interest from a GP already works in County Durham to join the practice as a partner, so they're going through that recruitment process. The PCNs and the federations, there were some concerns highlighted in David's report about how the arrangements would work when the 2 practices are currently in 2 separate PCNs and 2 separate federations. So we've had very constructive discussions with the PCNs and the federations, all 4 organisations, over several weeks during this engagement period on how services for patients in the 2 current practices would be delivered when they become a merged practice. Mature discussions have took place and they're quite happy to work out prior to the merger date for each contract whether services will be provided by Chester Street PCN or Federation, or whether geographically it makes more sense for the frontline staff that are delivering to deliver it from the Durham side PCN or Federation, and they don't see any insurmountable issues. I think there was, so that covers the boundary issues that came up in the report and concerns about multiple PCNs and federations. Thought that background would be useful. Should also say from an engagement point of view, this is one of the first engagements that we've done in this new COVID environment where a lot of the engagement has been virtual. So for the CCG, we've probably got, we were more involved in this engagement process for this merger than we ever have been, just so that we can support the practice through virtual engagement with patients.
Okay, thank you, Joseph. You've got your hand up, and thank you, David. Let me open it up for questions, comments, observations. Andrew?
Yeah, thanks, Faisal. I suppose it's a question just related back to the thing that Joseph's just talked about, which is the PCNs. We've seen over the last few years quite a few examples of practices merging, and that there seem to have been quite a number over the last 3 or 4 years, and that's understandable. Obviously, this is one solution in relation to the issue about whether it's 2 separate PCNs. I'm just wondering how messy this might end up getting in relation to PCNs, who's responsible for delivering what, where things sit. If we keep getting practice mergers that are from 2 separate PCNs, and whether there's a simple way of dealing with it, or whether this is just something that we're just going to have to deal with on a case-by-case basis as the mergers come through.
Yes, thank you, Andrew. So yes, this is not the first case, because we had a case in Easington where we had practices merging from 2 different PCNs, and of course, that by default, the practice code that remains is the dominant code, which is where the practices that are merging into, they would fall into that PCN. So, for instance, Gardner Crescent was already part of Chesley Street PCN. So, with the merger with Craghead, the Craghead patients will automatically fall under the Chesley Street PCN. Apart from when, as in this case, the PCNs or the federations make decisions different to that in the interests of patients. And so they are considering that flexibility, that there may be some services like extended hours where it may be best for the patients of Craghead to still receive that delivery from the Durham side extended hours arrangements. We have said as a CCG, we're very happy to facilitate the financial flows within the framework that Richard will prescribe, so that if there are services still going to be provided to the former Craghead patients by the former Durham side provider in the new arrangements, that the financial flow will be there for Durham side if they provide those services. So I think the question is valid as a position where it's in the best interests of patients. We're happy to facilitate cross PCN mergers. The merger supports the sustainability of the business, but having several PCNs or federations working into that new practice where it makes sense for patients, it's just a matter of us to facilitate the funding flows.
Thank you, Joseph, and thank you, Andy, for that question. David, Joseph, 2 points from me. I note the MP support, which is always great to get that political support, and the support from the Council's Overview and Scrutiny Committee, which again is good. But I also note that Pelton Parish Council raised some concerns in terms of the future of lavender. So could one of you comment in terms of those concerns, please, Joseph? That's my first point.
I'm quite happy on behalf of the committee to feedback the questions that have been raised by the community regarding the future of the Lavender Centre. I think it'll be up to the practice if they have plans to change their delivery configuration to go out to the public and engage with them on what the patient's views are. And I think that's that, and I will tell them that as this has been raised through this engagement, that if they have any plans to change the configuration, they must go back out and engage.
Thank you. And my second point, David, by way of introduction, you spoke about the transport implications. You can assure this committee that those transport implications for patients accessing the merged services are robust.
Yeah, what we've been advised as part of this is that all the sites will remain as they are, and the provision of services will be extended across all sites. So all patients should be able to access their own site or another if they wish to do so.
Thank you. Any other comments, observations before I go to the recommendation?
Yeah, I should say that, okay, particularly in the engagement feedback, they raised questions about lavender, and I've already responded. I'll go back to the practice if they're going to change their plans. We should also note that there is another practice in the Lavender Centre.
Okay, noted by way of a minute. David, Joseph, any final comments, or have you made your final positions? That's fine, and we've had a conversation. Can I take us to recommendation? The committee is asked to consider the content of the report, which we have done, And the recommendation is we agree to option, which is option 1, agree to the full merger of Gardner Crescent Surgery and Craghead Medical Centre. We agree totally, yes? Lovely. No abstentions. We shall move on. Bear with me, because I'm multitasking. The next item on our agenda is primary care quality report, and that's from Jason. Welcome, Jason, once again. But we've also got Anne Greenlee, who is in attendance to speak to this report. So I'll hand over to the both of you. Primary care quality report, quarter 1.
Thank you, Chair.
Thank you, Anne.
So I'll go through the report and take any questions at the end. So I think the key things to note in terms of this, it's the quarter 1 report. It includes the detail of things that have happened over the quarter, but key is that it's in the context of COVID-19 as well. So things that have been stood down have been identified within the report. Of note, the primary care network operational group meeting has been restarted in support of the network. So I think that's some things are actually coming back on track now as well. And there are other elements that are also being picked up within the other aspects of other reports. I think the key thing is, if I can refer people to slide 2 on the attached quality report, to note the NHS England Friends and Family and the Quality and Outcomes Framework submissions remain suspended at the point in time of the report. As reference to the next incident reporting, which we also picked up in the action log, you will recall there has subsequently been a meeting to discuss that, and there is a central incident team that will process all of those primary care incidents, and I think people were satisfied that that process of reporting and managing incidents from secondary care providers about issues that they identify in general practice will actually be a much more robust and clear process. The slide 18, I won't go through all of the report, clearly I will take questions. Slide 18, in terms of SERMs, I think the incidents reported by primary care, it is worth noting that the decrease in reporting has been what we've kind of seen across organisations as a result of COVID-19. So we do expect to see a resultant increase in incident reporting as services come back online. So that's absolutely in line with what would be expected. And I'm happy to take any questions in terms of the report, or if Jason's got anything else to add.
Thank you, Anna. Of course, I note on your report that we've got some very positive survey results of the GP patient survey, yes. But we have a formal agenda item on that, which is
exactly
excellent.
Yes.
Okay, Stuart, please. Are you muted, Stuart?
I am, Faisal. Thank you. Just on the SERMs reporting, I mean, there has been a big drop, obviously, in the first quarter of this year, which I presume is April, May, June, and so may well be due to COVID. But it's been dropping across the region for the 3 quarters before that. So it would be nice to know if you've got any explanation for that and what we're going to do about reversing that trend.
Yeah, I mean, I think the key thing is there has been a meeting with the quality leads. The medical directors have met with the next incident reporting team, and they're actually looking at and doing some comparisons in terms of what kind of best practice happens across other areas as well, Stuart. So I do expect that we can kind of better share best practice and hopefully drive that up. But I think, as with any incident reporting, it can become a little bit of, sometimes it can be a kind of perception of a lot of process and very little return. So I think the one thing I would absolutely be pushing is that we're showing the difference that it makes by reporting incidents, and really starting to encourage more of the lessons learned and why it makes a difference and why it's important.
Yeah, so it's something that, you know, has been an issue for a number of years now. I mean, I don't think SERMs has ever been particularly popular with GPs. And, you know, it is clearly important that that we do get incidents reported. But I do wonder if SERMS is the right model to do this, because it doesn't seem to have been used as extensively as we might have hoped.
Yeah, I mean, there are a number of incident, and Jason, I'm sure will come in on this as well, but there are a number of incident reporting systems. Nationally, there's a lot of work going on to try and some of that's been stood down, but we do expect that will kind of be picked up again, to try and make that incident reporting process and systematic joining up of information in systems as streamlined and easy as possible. So I think you're touching on 2 points. One, systems have to be absolutely user friendly, and it cannot be too onerous in terms of time to report incidents. But also, if people are taking the time to report incidents, what's happening as a result. So I think that kind of better sharing across the system. And I think we've got opportunities as we are kind of developing as a new CCG to better share some of that. I think, is Jason trying to come in? Sorry.
Jason, do you want to comment?
No, and I think I'm right, and the system's it's got to be user friendly, but also it's got to respond back to the person who's put the system in. But we've got to be able to use the learning much more on a health economy scale as well, just to make sure that we're not losing some of the information that's coming through. Because if we run the risk of looking at an individual incident rather than looking at thematic review, we might miss some of the nuances from a systems report.
Okay, thank you. Final comment, Stuart.
Yeah, sorry, I've got a second comment, which is on the report on practice performance. I mean, it's obviously very pleasing that we've done so well across the county, and that we don't have any practices that require improvement. However, we do have a few practices that require improvement in certain areas. So what are we doing to address that issue to make sure that none of our practices drop down into the league below?
Thank you. Who's going to take that, Jason? Anne?
Yeah, I mean, I think it'll be with the quality leads in the CCG, and I think as a new CCG, we've got a fantastic opportunity to really kind of work with all of the primary care leads and the quality leads together to try and drive that. I think we've got really good examples of nursing and GP leads working in primary care. So I do think we've got, if you like, the ingredients are there to be able to do that. I'm quite new to this CCG, so I can't kind of give all of the answers, but I can kind of say what I do know, what works in other areas, and hopefully we can seek people's views and seek to engage more and drive that up.
Thank you, Anne. Thank you, Jason. Just before I invite Dilys to come in, she's got a hand up. Points about continuous improvement, really, which is important, isn't it? Dilys and then Joseph, and then we're going to go to the recommendations. Dilys, please.
I was just going to say, just everyone has to remember how busy primary care is at the moment. We're catching up with the 2 or 3 months of very quiet activity. I don't suppose there were any SERMS events to record during that period anyway. But we're all planning flu. We're catching up with all the QOF stuff. It is really busy in primary care.
Thanks for that update, Dilys. Absolutely. Joseph, final comment?
Yeah, just quickly on SERMS, I think we still haven't got the feedback loop back to practices on the learning from SERMS quite correct. And also we don't probably profile enough where people stand in their lead position of SERMS reporting. I think those two things would help. As far as CQC is concerned, Stuart's question is valid. We've been quite reactive in the CCG to produce results. So when practices have fallen into requires improvement, we've got quite a significant input into helping those practices turn around. And they've all succeeded. COVID environment has changed the inspection regime. And so now they're favouring desktop inspections. And they've also now said that future physical inspections, when they come back into place, will be probably different. They're going to use COVID as the turning point to change their regime, and the focus will be much different. So I think there's a lot of learning for us to do to be able to anticipate how inspections will be in general practice in future.
Thank you for that addition, Joseph. And again, thank you, Anne and Jason. Are there any other final comments? Look forward to seeing Q2, Q3 reports as part of that ongoing learning and development. If there are no final comments, can we accept the recommendations as printed, which is we note and have discussed the content of the report. Agreed? Thank you very much. Moving swiftly on, primary care finance report for the 3 months ending 30th of June. This is always an interesting one. Richard, over to you, please.
Yeah, thanks. So this is the usual report, which shows both the delegated primary care budgets, which are the responsibility of this committee, as well as other areas of CCG primary care spend for information. So we have discussed previously the temporary financial arrangements that were originally put in place for the first 4 months of the year. So that involved a significant reduction in the previously published CCG allocations, about £2.3 million per month in total, of which £206,000 per month related to the delegated primary care allocations, with an expectation of retrospective fund and allocation adjustments to get the CCG back to a break-even position. So we have now had confirmation that those arrangements will continue to the end of September. The position beyond September is still unclear, so we're awaiting confirmation of that. In terms of the position at month 3, you'll see in the report we are reporting a £1.172 million overspend on delegated primary care budgets, with a forecast overspend of 1.7 million for the 4 months. Similarly, on the other primary care budgets, we were reporting an overspend for 3 months of £334,000, with a forecast overspend of 537,000. Now, subsequent to producing the report, we have received additional retrospective funding to cover the overall CCG overspend reported up to month 3. So that takes our overall position to break even. The allocation adjustment isn't split down to different budget areas, but effectively that would then cover the overspends we've reported on primary care budgets. So at month 3, we are break even now. I would expect a similar position for the next few months up to September. So ultimately we'll end up break even overall at the end of September. The other thing just to highlight on the final page where we've got the other primary care spend, you'll see that includes some primary care COVID related costs. So that is the reimbursement process that we put in place with practices from start of April to reimburse for additional costs. So it includes staff sickness, PPE costs, cleaning, perspex screens, that sort of thing. We have now had guidance from NHS England, which effectively confirms that approach. So all CCGs are now asked to put a reimbursement process in place to cover additional primary care costs up to 31st of July. So effectively, we've done that. We are still waiting for some guidance, further guidance around PPE reimbursement from 1st of August. So we'll wait for that guidance to then confirm the CCG reimbursement process beyond 31st of July. Other to that, I'm happy to take any questions.
Thank you, Richard. You do a great job, and the good news is break even considering the challenges that we've had in primary care. Outstanding. Thank you so much. Any comments, observations, any additions, questions for Richard? Including the named people at the bottom, just speak up. Nothing? Okay. If there are no further questions, Richard, thank you once again. Can we accept the recommendation as printed, receive the report, note the current and forecast financial position in terms of primary care budgets? And always to say, it's always useful to get the other primary care spend as well as the delegated budget spend. So good news. Moving on, we have, bear with me, risk management report, still with you, Richard, risk management report.
Yep, so still 2 corporate risks highlighted in the report, which are brought to the attention of governing bodies. So one around delivery of constitutional standards, and obviously one around coronavirus. There's further detail on both of those within the report. There's been no new risks added or any risks closed since the last report. Just one other point to note, though, since producing the report, we have reviewed the finance risk again and suggested we'll increase that risk up to a score of 12. So it will still be an amber risk, but the score will increase slightly, which just reflects the uncertainty in the financial arrangements beyond September and the potential impact that could have both on primary care delegated budgets and the wider CCG position. So we'll keep that under review as we get more guidance from NHS England.
Thank you, Richard. Questions, comments, observations, colleagues? If not, we go to the recommendation. Recommendation as printed. Sorry, somebody's speaking. Nope, sorry, I'll go back again. I'm getting used to this. We received the report and appendices, note the current risks facing the CCG, and receive assurance that mitigating actions are in place to ensure all of the CCG's risks are being appropriately managed. Agree that recommendation? Thank you very much. Moving on, Joseph, primary care and primary care network development update, please.
Thank you, Chair. So the report is self-explanatory. It shows all the good progress happening in primary care. I'd just like to specifically highlight that we quickly implemented, as per NHS England requests, antibody testing amongst all the primary care staff. That was supported and facilitated by the CCG with the relevant path labs, and only 8% of the primary care staff group tested positive. Care homes has been a significant amount of work. Care home DES, or the COVID offering, which brought forward the DES, meant that across the country, because it was an urgent imperative, there was a stronger alignment of primary and community care to care homes to support them during this crisis. In Durham, we went actually further than that. The requirement was to align a primary care network to each care home, nursing home, and in Durham we've actually aligned a GP practice to every single care home, and the local authority and the CCG, working with both the care homes and the practices and the matrons and the PCNs, has been a significant amount of work to create that alignment and do it with the support of residents, because that's quite a disruption for them when they have been with their own practice for so long and then they're being asked to consider to register with an aligned practice for the care home. But I think for most residents, this all the benefits of having one practice supporting the care of all the patients in that home outweighed the decision. We also supported general practice in doing risk assessments for all their staff, COVID risk assessments, whether they had BAME staff or not, so that every member within primary care has had a risk assessment now, and the practice has then supported those staff who've come out in a risk category where mitigation is required, and we are 100% on that. The LIS is also within this report, but I will ask Stuart to expand on that within any of the business.
Thank you.
I'm happy to take questions on any other parts of the report.
Thank you, Joseph. Comprehensive update in terms of primary care network development. Any questions? I have one. Appreciating the unprecedented situation we experienced over the last 5 or 6 months. Prior to that, we did do quite a bit of work in terms of looking to increase capacity in primary care, GP capacity specifically, and we went to Europe. What's happening on that front, Joseph?
Yes. So,
yes.
Sorry, Chair. I do have an update. So I've spoken to NHS England yesterday, who were coordinating this nationally with Next, who won the contract to support the international recruitment. The particular medical agency that was used for North Eastern Cumbria, that contract has now been finished. The only successful area to recruit an international recruit from this programme was actually County Durham. That GP from Europe is in North Durham. and nationally, NHS England have decided to move to a virtual model for international recruitment, whereby interested GPs will contact a central agency, and then it'll act like a marriage broking service to align them to a CCG where the European GP shows interest, and it's subject to them meeting all the requirements of IELTS, the IELTS language test, etc. So, in summary, the international recruitment programme that was heralded as part of the 5-year plan probably hasn't met the expectations nationally or even locally.
Okay, Stuart, you have your hand up.
Yes, I mean, just to say that, you know, GPs, you know, aren't the only way of solving this problem, and the PCN network does encourage practices to bring in additional staff that might allow some of the pressure to be taken off GPs. There is, of course, a minimum number of GPs that you need, and it is essential that we do continue to recruit GPs into this area. NHS England seem to have accepted that the partnership model is a good model and one that we should continue to deliver. As a result of that, there is now a £20,000 reward or loan, but it becomes a loan that doesn't need to be paid back if GPs take on a partnership for the first time and stay there for at least 5 years. So I do think we should be doing something around that to try and recruit more GPs into the area. Unfortunately, when we've looked at new young doctors coming out of training, the majority still don't want partnerships. They would still rather have a salaried doctor option. And I think we're doing something wrong, I think, in promoting the partnership model and all of the benefits that would come with that partnership model. So there is a lot of work still to do there.
So thank you for that, Stuart. Extremely helpful in terms of that partnership model. Maybe we can receive something in the future on what progress we're making with that. Joseph, I can see your wedding ring.
Oh,
yeah. Yes.
I'll quickly come in before Jonathan probably has quite a lot to say. Is that although I can't evidence it now because the counting of GPs employed in County Durham has changed through Healy just at the wrong time for us. Anecdotally, I can say in my whole tenure while I've been Director of Primary Care in both former CCGs, that the workforce issue is less of a crisis than it was. And we have all the initiatives that we did as part of a 5-point plan that came to this committee almost 3 years ago. I think the compounding of each of those initiatives, when you collectively look at the benefits, have had an impact in County Durham, namely GP career start, skills mixing, the promotion of nurse practitioners, especially in the south of Durham, the wider sustainability of general practice, the practice merger scheme that supported quite a number of mergers in the last 18 months that have come through this committee, have all had a positive impact on general practice, and I think we're in a better place than we were 2.5 years ago.
Thank you, Joseph. That proactive approach has definitely worked, and yeah, that's useful. Any other questions, comments, observations?
Faisal, it's Jonathan. Can I say a word?
Please, Jonathan. I can't see you, but say a word. Hello, Jonathan.
Look at you. So I totally agree. You know, it's a challenging time for recruitment, and a lot of practices aren't really sure if they should recruit now because of the financial uncertainty and so on. But just a positive word on the Career Start scheme. Just looking at the figures this morning, we've currently got 19 GPs on the scheme, which I think any area would, you know, give the right arm for. You know, it's amazing to have that many on your scheme. I've taken 3 further inquiries in the last week. So, you know, the scheme is pretty much at capacity. And you know, we continue just to function on word of mouth. We haven't paid a penny in advertising in about 3 years. It's just word of mouth, which I think is the best way. So for all the bad news out there, I think the Career Start scheme has continued to deliver for five years in a row, you know, and will hopefully continue to do so. That was a final plug there.
Thank you, Jonathan. Live from the front line. Great news live from the front line. Absolutely fantastic. as we live streaming. So if there are any further questions, comments, and those people listed at the bottom of my screen, please speak up as Jonathan has done. If not, we take the recommendation to note the report and consider the content, which we have done. We agree that. Bear with me while I go to the next one. Moving on, Joseph, you again. Oh yes, based on my request, GP practice staff and patient survey update. I think it's another good news story for us. Over to you, Josie.
Thank you, Faisal. So we have been before COVID, we were refreshing the primary care strategy. Refreshing the strategy got halted because of COVID, and in the light of the new norm being dramatically different to what general practice was, it will significantly influence the finalised primary care strategy. In line with that, it was the best time to survey both the patients and public and our own GP practice staff as to how they felt primary care going forward should look like from after their experiences with COVID. The patient public survey we started designing within County Durham, and it quickly got traction across the ICP, and it became a cross ICP survey with South Tyneside and Sutherland also joining in, and it being administered once across the public. I'm really pleased to say that County Durham had the most returns on the survey with 1,157 returns. Some of the key things that came out of the patient public survey, because specifically the survey was asking around how is general practice access for you and how has that changed because of the digital interface. And 67% of people experienced that were asked remote triage. That was a combination of 60% telephone and 7% video. The survey, if you've read it in detail, shows that generally there's been a massive culture change from the patients and a ready acceptance to this new mode of delivery, which is really encouraging. If we move on to the practice survey and the practice staff, the main themes that came out as they saw in terms of overall benefits was the remote working, the reinforcement of TAPS and supporting general practice delivery, the rapid change and move to digital and how that has actually supported general practice delivery, especially access, with most patients getting same-day access to the historic problem dating back to when it was first tackled in 1997 through the access scheme and never been really successful until now, are the main areas that have come through in the practice survey. So before I get asked the question, Faisal, I think although the surveys were done separately, we've brought it together under a combined paper, and as a primary care committee and as a primary care team within the CCG, it's quite obvious the areas that both patients and staff would like us to consider going forward as embedding within primary care, and that will be reflected what the results have come back through into the primary care strategy. I think it's quite unique, if I may say, that we're developing a strategy and we've been able to get the views of patient, public and staff at the same time.
Thank you, Joseph. I was going to ask, but I think it's fairly clear that the question is so what? We've got this information. What impacts does it have? But clearly our primary care refresh strategy will reflect those views, as you've rightly said, and an action plan will come from that in order to implement, for example, digital inclusion. What timeline are we working on, please, Joseph?
So I think we anticipate bringing the refreshed primary care strategy and action plan to the November primary care committee.
Thank you very much. Great. Changed world, different ways of doing business. Any further questions, comments? And also, Amanda, Sarah, your name was attached to the report. Is there anything you want to add? Sarah Burns. If not, that's fine. But your name was attached to the report.
No, Faisal, it's there as the engagement team coming to me, but I would just say it's a really good piece of work that the team did.
Absolutely, I agree totally, and thanks to primary care and the engagement team too. Can we accept the recommendation as printed? Receive the report, note and discuss the content. All agreed. Thank you very much. Right, switch. And of course, continuing to tell the story about primary care, we have the NHS England GP patient survey results. Back to you, Joseph. Another good news story, I would suggest.
Yeah, I mean, I work very closely with the quality team, and it's through Susan Hepburn supports me in terms of analysing the results of the annual Mori poll, and then we always take that to the quality committee. This hasn't gone to quality committee yet, but I think it shows that County Durham are very patient-centred. I think the responses are good. I think what we should notice, this may be the last time the Mori poll uses this format of questions, because I think in the new world of primary care delivery, a lot of some of the questions may no longer be relevant when it comes back round in January. So it'll be interesting to see what the design of the future Mori poll will be. And if we can get a heads up, it'll be good to let general practice know, so that they can actually focus from a customer experience point of view on what they'll be measured. Also have to say that in the past, we've used, even though this is purely for individual practices and they can download their own results and it's their responsibility to develop their own action plans, we've gone further as a CCG, and I'm sure the quality committee will recommend the same when it goes to committee. We've actually supported the practices that have been low on specific areas in the survey or low overall, and helped them to develop an action plan that supports improvement for future Mori poll. So as a CCG, we've took it on as our responsibility to support practices whose Mori poll results have not been as they desired, and it also supports their CQC process, because one of the areas that CQC look at across every practice, whether it's desktop or a formal visit, is the Mori poll results, and they like to see that the practice has an action plan, or an improvement plan, should I say, for areas where they scored below the CCG or national average.
Thank you, Joseph. That's absolutely great news again. And Stuart, please, you have a question. I think you may be on mute. I think you're on mute. Well, you are on mute, Stuart.
Sorry, I am. I was on mute. I'd just like to kind of congratulate the team on those kind of excellent results in those polls. We did also do a survey of general practices during the COVID period, and we got a huge number of responses and comments from primary care. Now, as far as I know, that was drawn up into a report by James Larkham, but I'm not sure if that's been to Primary Care Commissioning Committee yet, and are there plans to bring that, Joseph?
So we could have included as an appendix James's report, the highlights of that report. There are some bullets contained within the previous report, but actually in retrospect, it would have been useful just to have brought James's report. So I'm quite happy to have that for information at the next committee, just to complete for completion.
Okay, thanks, Joseph. The other thing I was going to say is that report was taken, just past the peak of the pandemic. It would be interesting to see if people's views have changed after that. And I wonder if before we bring it back to Primary Care Commissioning Committee, we should send that completed report out to general practice and maybe ask if they've got any further comments to add now with hindsight, looking back on what's happened.
Thank you for those. Thank you for those suggestions, Stuart. Makes a lot of sense, really, in terms of pursuing that course of action. Okay, Joseph, we'll do that, and it's been captured on the minute as an action plan. Yeah. Can I just reiterate your congratulations, Stuart, to primary care teams across County Durham. It's absolutely excellent in terms of the way that they continue to work in these difficult times and beyond. Joseph, do you have a final word on this, if there are no further questions?
No, I just think Stuart's proposal is a good one. I have a feeling, so I'll go back to James Larkham, that I wouldn't be surprised if the RCGP think the same way, and they go back out to the primary care asking as this far into new norm, how they feel. And therefore, if we've run our own survey, we're probably able to give a good reflection of that.
Fantastic. Thank you for that. If there are no further questions, I'm going to go to the recommendation. Recommendation as printed. Note and discuss the content of the report, and there's some further actions in terms of follow-up that have been suggested. So it's being recorded, so we will capture that. Thank you for that, Joseph. Moving on, we're expecting Ian Davidson to do a flu update, so we'll come back to that if that's acceptable. We don't have any questions from the public. It's all being live streamed. I'm going to take us to any other business and invite Stuart to update on local, is it local implementation scheme or local incentive scheme?
Local incentive scheme, Faisal.
Thank you.
Yes, we've always had a very extensive local incentive scheme in Durham, and the incentive scheme was always designed mainly to encourage primary care to take on work that had traditionally been done in secondary care. We know that much of the work that is done in secondary care could more easily be done in primary care, could be more efficiently be done in primary care, and of course primary care is much more convenient for patients if they can access services there. Now, this year we had promised primary care that we would put in place an element in the local incentive scheme around prevention. It's obviously a really important issue to address. But when COVID came along and face-to-face consultations became impossible, at least on a temporary basis, we realised that we could not implement the prevention part of the LIS. When our hospital services then started to restart their services and change the way in which they work, so they moved more to virtual consultations, we realised that many patients would still have to come into a hospital environment to have their bloods done and some other investigations done, pre-op swabs being another area that they would have to come into a hospital for. So we decided to divert that money that had been aligned to prevention to support the delivery of virtual secondary care clinics in primary care. So we've developed a standard operating procedure. The consultant in the hospital would still take responsibility for the test he's ordered, but the mechanics of doing it would take place in the GP surgery, usually using a healthcare assistant. The result would then go back to the hospital, and any action that was required would be taken by the hospital consultant. So convenient and safe for patients, and they wouldn't have to go into a potentially a slightly more risky environment in the hospital, particularly important for people with cancer and for people who are maybe going in for a major operation. Because we were implementing that for acute services, it seemed only right that we also introduced that for mental health services and tried to put in place a similar SOP with Tees and Weir Valley. Now, that has been a source of contention with some of our practices, and we had a letter from the North Durham practices, mostly in Derwent, but also in other parts of the North Durham area, where GPs wrote to the CCG to say that they wouldn't take up the LIS, the new LIS, the altered LIS at all if that mental health element remained there. So because it is really important that we get the acute clinics up and running, we've agreed to remove that element, but we have found some additional non-recurrent ring-fence mental health money, which we're going to use to try and make sure that those practices that will still take up the mental health element get some reward for taking on that additional work. That will also allow us the opportunity to finalise the SOP with those practices, to find out what the workload really involves and to bring that into the LIS for April of next year. The prevention aspect is important, and the PCN DES will eventually cover prevention, and we expect that new money will come down for prevention next year. But what we were trying to do this year was to get a step ahead of the national enhanced service and put it in place early. So we haven't lost anything by delaying. It was impossible to put that in place anyway because of COVID, but that money will still be forthcoming next year as a national enhanced service. So that's it in a nutshell. Happy to answer any questions on that.
Thank you very much, Stuart. I must say I agree with the rationale and the principle behind that in terms of the move from secondary care to primary care with a focus on prevention. I have a question, but Nicola first, please.
It was just a point, really, just to support that, and also the real need to make sure that we don't discriminate against people with a mental health issue and treating those individuals any differently to anybody with a purely physical health issue. And I think that's a really important principle that we need to uphold whilst acknowledging all of the issues that are for further discussion.
Thank you. Stuart, it'll be useful to bring a report back to this committee outlining progress in terms of the local incentive scheme and what we're doing and so on and so forth. The question I have, though, I guess, is appreciate the point you made about resource available to support implementation. But from a primary care perspective, do they have the capacity, and we have clinicians amongst us, do they have the capacity to deliver on a range of services? I have no idea what those services are, maybe taking blood, I don't know. But do they have the capacity? And can we support them to do that?
So it's a bit of an unknown at the moment, Faisal, but having looked at the number of bloods that are requested at the moment through CDDFT, we think that the number of bloods in particular that will be done in primary care is very small, and should and is probably manageable within their current resources. But the additional funding should allow people to increase the number of hours that their healthcare assistants provide to cover any additional bloods that need to be done. With regard to the mental health issues, most practices admit that they're already doing most of that work already, but the objection from North Durham seems to be that it's formalised and becomes a contractual requirement, rather than it's being done on a bit of an ad hoc basis at the moment. And I do hope that the North Durham practices, even if they don't sign up to the LIS, will continue to deliver those services for patients with mental health problems if they can't get to a mental health facility. I would be pretty appalled if those patients were referred on to a less convenient service just because the GP didn't want to do that particular test for their patient.
Absolutely, and I guess we're going to monitor this very closely. And part of the range of mental health services will fall under IAPT, improving access to psychological therapies. I would have thought, Stuart, correct? Or is that different?
That's different.
Okay.
Different. So it's mainly the monitoring. It's the monitoring of patients, particularly those on medication. So it tends to be bloods and ECGs. Sometimes people with an eating disorder need fairly intensive monitoring or weighing or things like that. So it's those sort of things. So it's not complex work, but it is work that some practices feel they don't have the capacity to do, and that's why it's so important that we audit it, find out how much work it does entail, and make sure that it's adequately funded.
And I guess any reporting will go to our quality primary care subcommittee, and they will deal with such issues, and we'll get a report at some point in the future to reflect and report on that audit to ensure that nobody's being discriminated against, but people are receiving that service. Excellent. 100% behind the rationale and the principle, Stuart. Nicola, 100% behind it. I think it makes a great deal of sense. The move from secondary to primary care. Further questions, everybody? No? Any comments? Thank you for that update. So Ian's still not here. I don't see his name on the list. The second any other business I recall was any update in relation to our offer with public health in support of the local outbreak in North Durham and Stanley Empire. Are we involved? Are primary care teams involved? If so, how and what are we doing?
So maybe I can answer that, Faisal. I mean, our involvement from primary care has been relatively peripheral. It's been a public health test and trace initiative at the moment, and I suppose it's really just a matter of primary care being vigilant, looking out for people in that area that develop symptoms and making sure that they're tested very rapidly and quarantined as soon as they become symptomatic. So we've told all local practices already that this outbreak has happened. I mean, obviously they'll have seen it on the news as well, and we will make sure that the details and any updates go out to all of the practices across Durham on our weekly headlines.
Thank you, Stuart. Important, much appreciated. Right, Ian's still not turned up. There's a paper attached. Would anybody like to speak to the flu campaign report in Ian's absence? Anne, Jason, Stuart?
I'm happy to have a go, Faisal. Let me just get the paper up. I mean, obviously, the worst thing that can happen this winter is that we finish up with a second peak of COVID and a epidemic of flu. We don't know when we're going to get a COVID vaccine, but we do know that it's very likely that any COVID vaccine will have to be given 28 days after any flu vaccine. So it's really, really important this year that we immunize as many people as we possibly can for flu as soon as the vaccines become available. Now, whereas we have to immunize as many people as possible, we also need to make sure that we immunize the most at-risk people first, and that is what's going to cause us the problems. How do we make sure that the vaccine that we have at an early stage is used appropriately on those at highest risk, so that they're the ones that are ready to receive the COVID vaccine should it arise at a later date? The other problem is that we have to, we will be expected to deliver the vaccine to a greater number of people, to hit a higher percentage of people at risk, to hit an extended age group in the children, taking on the Year 7 children this year. And we will also have to start delivering the vaccine to anybody above the age of 50. But again, the people above 50 that are not at risk at the moment need to wait until we know that we've got enough vaccine, and so we'll be towards the latter end of the vaccination season. The other problem we have is that GPs order the vaccine nearly a year in advance. So trying to order increased amounts of vaccine to deliver this greater number of people that we expect to immunise this year has been difficult. We've managed to order some additional flu vaccines, but we don't know yet if it will be enough. We then have the issue over delivering vaccine in a socially distanced way this year with PPE, where the gloves and apron at least will have to be changed between patients. The information that the patient has been immunised needs to be put onto a computer, and so those workstations need to be far enough away from the patient to be COVID safe. And so the whole process this year is likely to be a lot slower than it has been in previous years. In some areas, they're looking at delivering the vaccine in larger venues, community halls or church halls, and I think Darlington are going to be looking to do immunisations in either the rugby or football ground. But many of our GPs are planning to reorganise their surgeries in order to get that flow of patients through the surgeries and to get people immunised safely. The housebound are also an issue, and of course our care homes, it is really important to sort out. But as Joseph has already said, we now have PCNs aligned to care homes, and there are plans in place for the community nurses working with the PCNs to go into care homes and to immunise not only the residents there, but the staff as well, again, to make sure that our most vulnerable groups are covered at an early stage by the vaccine. People with learning disabilities have always been a challenge, and there are plans to try and be more proactive this year than we have been before to make sure that this other vulnerable group is immunised, and we immunise more people this year than we did last year. Pregnant women are also an issue. And for the first time ever, we have got all community midwives and hospital midwives trained up to give the vaccine. So hopefully we will see an increased number of pregnant women immunised this year. We're also looking at delivering the vaccine as part of an integrated system this year. So we've asked staff from the CCG and the local authority if they will come forward and volunteer to go out and help general practice to deliver the vaccine this year. There really isn't anything more important this autumn than to try and get as many people immunised as possible. So it's important that we all try and muck in and help, particularly primary care, to immunise this year. We're also encouraging our PCNs to work with our pharmacies and to try and coordinate who they immunise. That's difficult because there's always been a bit of competition between pharmacies and primary care with regard to the number of vaccines given and who gives them. But it would work an awful lot better if we can come to some agreement with our community pharmacists and do this in a coordinated way. So I hope that I've covered everything in the paper with that rambling. But if there are any other questions, I'm happy to answer them.
Thank you very much, Stuart. An extremely comprehensive update. And for the record, you have my full support in any way I can volunteer to assist primary care. Pushing a trolley, carrying tea, whatever. Making tea. You let me know. Are there any questions? Joseph, did you want to ask a question? No.
It was just
in
support of Stuart's report. PCNs and practices have looked at innovative ways of delivering that might cut the time because of the restrictions. So we did ask practices whether they wanted to do it at scale like Darlington, but most practices feel it's best that they deliver it individually as their own practice, which also correlates with the previous report we've had from the patient feedback that asked them the same question. 70% of patients said they would prefer it at their own practice. So that's good to see that primary care patients are thinking the same way. It's also important to note that for general practice and community pharmacy, we've asked them to over-order in anticipation that there'll be a greater uptake of flu due to the fear of COVID. And specifically with primary care, we've offered to underwrite any flus of the additional 10% they order that don't get used because they're doing this at risk. We will require volunteers to help. Some practices are going to do it outdoors, almost as a drive-through where people stick their arm out the car and actually getting traffic going past the surgery and through a one-way system and toing and froing and everything. We'll need a lot of support to do this in a safe way that reduces the rate of infection or doesn't pose a risk.
Thank you, Joseph. You've got that support from me, definitely. Dilys, you had
I was just going to say that every practice in PCN has to submit a detailed plan by the end of the month to Kate Huddart, the prescribing lead, on how they're going to run the clinic. So hopefully everyone has thought very carefully about the process.
Lovely. Thank you, Dilys. Stuart, final word on this, please.
Yes, just to add, there is also an expectation that NHS staff will be universally immunised this year. So 100% of people immunised, unless you have a contraindication to the vaccine. So that is an expectation of our staff this year. And again, in Durham, we have the highest rate of staff immunisation in primary care in the region.
Yes, over 70%, yes.
Yeah.
Lovely. Thank you very much again, Stuart, for stepping in and providing us the comprehensive update on flu. The report's attached, the recommendation as printed. We note the work being undertaken by all partners to ensure patients are vaccinated for the 2020-21 flu season and the implications with COVID-19 of the vaccination programme. We agree with the recommendation. Thank you very much. Stuart, okay. Moving on. Risk roundup. Richard, anything in terms of risk roundup? Anything new? Nothing.
Don't think there's anything identified. No.
No. Nicola, anything on the risk roundup? No, thank you. If not, the date and time of our next meeting is Tuesday, the 20th of October. I thought it was in November. 20th of October, and arrangements to be confirmed. There's nothing else. We conclude the Primary Care Commissioning Committee. Can I just say this being the public part of the meeting, we now will go to a private part of the meeting to discuss a few issues. So those that are part of that agenda, please stay on, don't go anywhere. Goodbye to the public and to live streaming. Lee, can I just check that?